Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello, everyone, and welcome to Sensei Podcast. It is my great pleasure to introduce our guest today, who is Dr. Bernhard Reimers, the Director of Interventional Cardiology at Humanitas Hospital in Milan, Italy, one of the proponents and one of the worldwide experts in complex PCI, bifurcation PCI. He's educated literally thousands of people through his hospital and the many meetings he's organizing, which we'll talk about down the line. So Bernhard, thanks again for being today in the podcast. Super excited to discuss with you.
Thank you. It's a great honor being with you, and of course a great pleasure being with a friend for an hour.
That's wonderful. Bernhard, always want to start this by asking people how they started. What did you always want to become an interventionalist? Did that happen somewhere in the way? How did this happen for you? Become a cardiologist, interventionalist, and doing complex stuff?
So I decided when I was 13 back in Germany to become a doctor because I was in and out of orthopedic clinic with broken legs and so on. And I wanted to become an orthopedic surgeon and a doctor. So then when I finished school in Germany, my A-levels weren't really so good. So there was closed number in Germany and I had to go somewhere else. And I worked as a assistant nurse for a year, and then I had the money to go to Italy, where I started my studies back in '84. I met my now still wife after 6 months of good life in Italy, and so I started medical school. I stayed there, and after 6 years. I finished. I graduated from the medical the school in Padova. Then I went a year to UK, but I did internal house officer of internal medicine because I said, well, I still have to learn a little bit about medicine. I cannot become a surgeon right now. And then my wife wanted me back, and she found me a place in cardiology, intensive care, coronary care unit. So it was really by chance that I happened in cardiology, and I'm very happy that I haven't become an orthopedic surgeon. Maybe my car is smaller, but I still enjoy my job.
Well, I guess it's a loss for the orthopedic surgeons, but again for the cardiologist. So you said, for intensive care, cardiac intensive care. How did this involve into intervention and that part of the work?
See, I did the fellowship then back in Padova, and it was really close. It was only a few meters from coronary care to the cath lab, and cath lab was a little bit the place to be. And I then decided, okay, let's try there. And then we did some Erasmus in Rotterdam with Patrick Serrois. For 6 months, the last part of my fellowship. And actually, there in Rotterdam, I met Carlo Di Mario and also Jaap Hamburger, who did the first CTOs with a biplane. And also Antonio Colombo was there a guest to see them at work, of course, at Rotterdam with Patrick. So there I saw my first stents cut half, and also some CTO procedures. And then the idea was clear. And when I came back, Colombo asked me, because Carlo Di Mario suggested it, can you start with me in Milan? And I obviously said immediately yes. It was 95. And I think some months later, also Carlo came from Rotterdam back to Milan. And so I spent my first 2.5 years with Colombo in Milan and at Colombo's clinic. And what was a really very, very intense time. And we saw many things, new things.
So these were the early days, right? Excitement, the stents, the antiplatelet anticoagulation, lots of very heroic times, as we'll say now, and obviously very, very much more challenging. Um, did
Yes.
you did you enjoy that in level of intensity, having the complex cases, having the complications? How was your approach to these cases?
Okay, complex cases, of course. If you work with Antonio Colombo, you don't have to look for them. They're all pretty much complex. At that time, complications were really very frequent. We actually had, I think, we needed to have a couple of complication meetings at 6 o'clock in the morning, generally twice a month, to discuss them. Losing stents, rupture of arteries, going into bypass surgery, and of course also fatal complications were much more frequent. It was also the time of the beginning of Rio Pro, and so we had also bleedings. So definitely complexity and complications we did not miss. The very good thing, if you are exposed to them and if you have on your side Colombo, Di Mario, you also learn how to come out of many of them. So actually, I think I really, when there is a complication, my heartbeat goes down by 10 because I know I have to concentrate now, and it's really one of the moments where I get cool, probably because I saw quite a many. Yes.
So this happened. It didn't happen automatically, right? It's a result of all your experience and having all these cases that you're able to control things.
Yes. We are very much exposed to complications, and it's also something I really like to teach to the fellows, where also the teamwork, the team approach to complications, which we took a little bit from the aviation industry. This is something I like very much to transmit because. Of course, if there's a complication, but you save the patient, that is very, very valid for us, of course, not only for the patient.
Wonderful. And then, how do you actually maintain that? So you've seen the complication, you know kind of what to do, but people sometimes start running. There's anxiety in the cath lab sometimes. Maybe some operators are not as experienced and able to keep their calm. So how do you kind of control the situation and transmit that calmness to the remaining of the group?
Well, it's that you continue to work, to move your hands. You try not to raise your voice. You give clear indications. And it's not always the first operator who has to give the indications to the anaesthetists, to the vascular surgeons, to the nurses, to ask for blood and so on. So there is definitely one communicator who does a little bit of talking, and the one who continues to work. Really, you have to be there and try to get everything calm, think, look at the pictures, and it's really you have to get your heart rate down and try this calmness, a little bit this experience to transmit with gestures, with some words to the other people in the cath lab.
Wonderful. And then how do complications affect you? So apart from the acute management, things may go well or may not. How does it affect you later on? Are you kind of obsessing about those? Are you getting depressed about those? How do those affect you later on?
Interesting question. of course, a complication, the patient survived, gives you a lot of endorphins. So you feel relieved, happy. The same, you should always do an analysis because beyond every complication, there is a human error or misjudgment. So this is if it doesn't finish fatal or not a major stroke, of course you feel a relief. If there is if it's fatal, I of course. First thing, you don't have to think about yourself. You have to talk to the family, which is the most important thing, to get the family a little bit on your side, to grieve together with the family, which is very important. Where you have to show really all your empathy, and so if you are destroyed, of course, after a fatal complication, the work is done after. First, you have to talk to the family. Then you have written the notes, the charts, very well detailed what happened without omitting everything. So this is you have to concentrate a lot, and finally to talk, of course, with your colleagues, with the nurses. Okay, and then you go home. Of course, you are depressed, and then it's not so easy to sleep well the first nights, and then of course you have to continue to work on it with the complication meetings and so on. If it not happens to me, the complication, because I'm doing also less now, but to some co-workers, fellows, and so on, of course you have to talk to them why it happened, and then it's well, we elderly, we have to first get them to get confidence in their work again, not to be too depressed, and the best if it's a TAVI complication, do the next day and a couple of days another TAVI. It's a coronary complication, do immediately another case because, of course, we don't want people to lose confidence. And it's clear that you will not forget this kind of complications. And okay, I cannot maybe give you the names of all fatal complications that I have, but I think I very well, most of them I remember.
And then, Bernhard, when you planning for the cases, how does the planning process come now, and has that evolved over time? How do you plan for the case and prepare the strategy for tackling it?
Mm-hmm. Good question. Of course, everything starts, talk to the patient, if there's family also, telling that there might happen something, because in case of complications, makes it easier. The case itself, okay, we still, not for the CTO cases, but for many cases, you know, that the ad hoc angioplasty is quite frequent. So, of course, in case of ad hoc, you cannot prepare so much, but you definitely have to take, if it's not an acute situation, some time to organize the strategy. And actually, if I find a senior colleague, I talk to a senior colleague. If I find a fellow, I talk to the fellow. If there is only a nurse, I talk to a nurse. If there is a stone, probably I would talk to the stone to discuss the strategy, to give questions. What would you do? And then so that even though maybe you know immediately what you want to do, but you discuss it and you put yourself always into doubt. I have to say again something I learned from Antonio Colombo. So ad hoc interventions anyhow definitely discuss the possible strategy. We now started here also, we give a green, yellow, or red light according to the potential complexity or also the risk. So we know for red light, we definitely stop. We talk to the patient, to the family, and when we start or we get them off the cath lab. So this is from for the not technical, let's say. Then for CTO procedure as well, you know that I work with Gabriele Gasparini here. I think it takes him an hour to look at the angiograms and think together. So I'm a little less because I'm less into CTO, even though I started quite early. But again, you have to the strategy you should discuss with somebody and have your ideas quite clear and keeping always in mind the complexity, the possible risk of your patient. Ejection fraction is low or is not low, calcium, and so on. But well, you know these things, so it's doable. So you don't have to
Sure.
lose hours and hours if it's not the live case for some congress. But you definitely have to have a strategy.
Wonderful. And then when it comes to teaching the fellows, the young colleagues, what do you find the most difficult thing to teach them when it comes to, I mean, any case, but especially the complex cases?
Uh, okay, there's two types of teaching. Because one is definitely, which I always want from the fellows, the younger fellows, that they think the same way I do thinking. They should be able to anticipate the next move. Like, you know, a good nurse does absolutely is able to anticipate the next move, but also a fellow needs to anticipate the next move. So I know he is in the procedure. He understands what we want to reach, what we want to do. So first wire, then put a stand or predilate, prepare well, then post dilate, and so on. So this is he really needs a little bit to be in. Then sometimes a little tough, you know, when you get older, that when it takes him a lot to get the wire down. Well, maybe in the morning I'm a little bit more calm. Okay, I wait until it's done, and sometimes let me do it. And then at the end, I'm not faster than them generally, but I took over. But I think teaching is not only by doing, but also by seeing from side of the fellows. But definitely, what gives you most satisfaction in our work, also in my present work, is to have the fellows, and that's like this for the last 25 years, because as I say, I can discuss with them. I don't need to discuss with the stones. And at the end, if they become better than me, look at Gabriele. He definitely became better than me. I have Saka, where I was teaching peripheral angioplasty. He does definitely better than me, and that makes me proud. So I'm happy, and then sometimes I'm also happy when when I come in and the wire crosses immediately where somebody else did not. So that makes me also some some vanity always. Sometimes you have, but teaching is probably the most important thing that we do, and maybe also because I come from a family of teachers. My grandfather, my father, my sister are all teachers, so genetically, I'm do that very happily.
Well, it's great to carry on the family tradition. Um, in terms of the teaching, and when you see a fellow, can you tell when you first start working with them if it's going to be uh, a great one or not? Is it something you can immediately tell, or have people surprise you? Sometimes you think one way they're going to be great or not, and vice versa.
I think I give everybody a chance, and not a single shot chance. as I said to you, if he has a complications, I don't say no, do electrophysiology or do echo. No, the next day come in again. Of course, he needs to be prudent. He needs to be learned. Sometimes you have also to shout at them, but. Okay, we are no microsurgeons. Okay, it's not impossible, I think, what we do with our hands. And so for me, I cannot tell after the first angioplasty this will be a great one or this will be less great. If he wants to, he can reach achieve many things. So you shouldn't really judge at the first impression. Maybe because also me, at school I wasn't that good, but then at the end I became a doctor. When I did my house jobs in England, the first on call, they nearly threw me out, and for the first month I had to call a locum to look after me. That I did the right decisions. After 6 months, they gave me a new contract. So never judge a book by its cover.
Perfect. And then, Bernhard, you've done a tremendous work on education. So many meetings, Toby, by the COVID Live Aid. I mean, so many meetings you've been organizing over so many years. How did this happen? And what was the incentive, and how difficult was it to get it up and running and have the impact that it has over so many years?
So maybe I start from the very beginning in 1997 or 8, I cannot remember. There was the Stent Summit in Milan, still working with Antonio Colombo, who always did his meetings. So I was exposed to them from the very beginning. I was scrubbed with Zamokato, I think a little bit the founder of Japanese CTO. And well, he was wiring a lesion, and he had the really used the wire very distant from the Y connector. And he said, "Oh, I can feel here some resistance." I don't think even it was the CTO. Some resistance, some calcium. And I laughed because we were so happy when we got the wire down. We couldn't imagine that you could feel something there. And that was really when I was when I got started for this to admire these congresses and learned even more from the live concept. Then, small parenthesis, I think the first paper on Asahi wires we published in the American Heart Journal in 1998. When they came directly, Kato brought them from Japan, and so we published a series, I think, of 80 occlusions with these new wires, and they went quite well, but we didn't really know. Then we heard about all these Japanese, or we saw these Japanese operators, and I said, no, the best way to learn is to get them to our hospital. They were already traveling a little bit proctoring, but I said no. But then it's only me that learned. So we started to organize the Toby Congress, really to get the Japanese operators down and show not only to me or to my cath lab, but to a greater audience their skills. And that's how actually Toby started to have the in-house training.
Amazing. And then, Toby is bifurcations and the total occlusions, right? So how did the bifurcations come into the mix? Was it something you were always excited about?
Yes. This is, of course, again, the 10th time that I have to mention Antonio Colombo, but he is my master, really my best teacher, and he's now working here with us. And he's still still teaching us new things with enthusiasm. I think he developed 80% of all bifurcation treatment solutions, and so of course we were all into bifurcations, and so
Perfect. And
we
again,
mixed it also to have, which was maybe also a little bit foreseeing because all the CTO courses now become CTO and complex cases, and we had this a little bit before.
so only 25, 30 years before. So that's
Yes.
well ahead of the curve. But you're right. I think people finally catching up. And as you said, it's interesting that so many years later, there's still so much confusion, I think, amongst many people on how to actually best treat the bifurcation. So um, how about the live case? As you mentioned, you learn in the live cases. How useful do you find them for people? Because some people are saying, "Well, it takes too long. Is it really worth it?" What is your thought about the live cases and how useful are they as a learning tool?
Okay. I think first of first of all, they are also useful for me and for my patients. We did with Sievert at the time also, that was carotid angioplasty. We looked at the incidence of complication live versus non-live, and they were absolutely equal. During live cases, you definitely have also the aid of experts. Of course, if there is in the panel some fellow German sitting who only wants to give you a hard time, it's maybe not that nice. But generally, you try to, if you're on the panel, to give a hand and not to disturb. So I think live cases come out maybe differently, but definitely not worse. Still, our profession is one of the few professions. I think also the GI, the gastroscopy people are similar, where also live cases still survive. Because, well, we don't look at the patient, we don't really touch the heart, but the wires outside. So you learn a lot from a live case. So I think it's still worthwhile, and the reason why people like to come to congresses with live case and this in the box are not really so sexy, and nobody goes and sees, or not so many people like them. So I think it's really for our business, it's still something which is very very useful. And again, for your CAS lab, to survive a full day of live cases, it's a highlight. You have to work together. Everything needs to be smooth. The quality of a CAS lab, which is used to do live cases, is, in my eyes, higher than one that does not do them in a proper, because you're a little bit more under stress, you are observed, but you have to do well. So I think they are still absolutely useful.
Perfect. So essentially, as you said, it can be used as a tool for improvement because you have the observation, the stress, but you also get suggestions, and you have to be on the top of your game, which is a great motivator, as you say.
Yes.
So, busy clinical practice, organizing all these meetings. How do you keep up with all this? Do you have any? How do you keep your energy and motivation?
Uh, Well, I'm now getting better and better to delegate the work, Toby to Gabriele and Jacopo and Damiano. So I'm getting a little less involved. But of course, I support everything. The toughest thing nowadays is to collect money. It always was a little tough, but let's put it 20 years ago, you had to decide in which castle you get your menu with a big party. Now to get the money for the transmissions and maybe to get also some speakers, not only online, but in person to the cast lab. So collecting money definitely has become quite an important problem. The logistics with the patients, you have to prepare them, you have to spend more time with family, patients, with the nurses. But again, bring, as you say, your performance at the top. At the end, it pays off, because then the month after, you still strive to the top, and you may improve. So it's a little work. Personally, following COVID, I do not travel much anymore for congresses. Getting a little bit maybe lazy, but I also like very much here to have everything a little bit better organized. Maybe in the hospital, I spend some more time for this. Definitely, but it's quite some time before. Prepare PowerPoint presentations. I very often ask a fellow, because the time I did steal my children and my wife doing PowerPoints is a lot. And I'm not sure whether it was something I should have done or I shouldn't have done. Anyhow, now I'm a little bit more free of this.
And then I know you're an avid biker. You like to. How does exercise fit in your life and keeps you in good shape?
Again, doing sports in the weekend, it's at least 4 or 5 hours on the bike, or walking or riding, and maybe half an hour a day. Takes a little bit of time, maybe reading an article, writing an article, preparing a talk. You have more in your hands afterwards, because after cycling, the only thing you have to do is to have a shower and eat something. But what I feel, definitely, I feel much better. So for me, it's kind of drug which I need for myself and my well-being, and so I definitely find the time. I don't know if you can see my office.
There you go. That's the secret to success. There.
Yeah, James Spratt has the same office, so it's nothing new.
No, but I mean, obviously, staying in good shape, makes it easier to do these long cases, and there's the mental component, maybe, as you say, that is quite important as well.
Yes, but
Um,
everybody finds his way. I think Jeff Moses, Colombo, they never did any sports, and they're probably better than me to do the cases. So everyone has to find his own recipe.
and then, how about any favorite book or any favorite movie that you have?
So favorite book. I think the one I enjoyed most is Don Quixote de la Mancha di Cervantes, because it's very funny, kind of ironic, which definitely helps you get through the world. Second books is Dickens, Great Expectations, and so on, because they also, everything gets always worse. So the books are worse than life, and that makes me gives you a little bit of optimism. So this is the books that really left a lot on me. But I read really a lot. I like reading very much.
Wonderful. How about any movies that are favorite?
Well, Kill Bill, without any doubt. I don't know whether part one or two, both of them. And every 3 months I have to see them at least.
Wonderful. And then, what are the things that you are most proud of so far that you've achieved?
um, well, of course, out of business, family, children are well. I think on Monday I'm married 30 years, so that's also
Congratulations.
thank you, an achievement that definitely makes me proud. Professionally, so in Milano, the Venice area, I think we formed really a school, and from my assistants, all of them became now chief of cardiology and cath lab. So I think this is also, which I'm very proud. And now here I have the same occasion in Milan to form doctors again and the fellows all over the years. I think they're the teaching I'm really proud of. Scientifically, well, I very much liked my work out a little bit of coronary business, the carotid stenting. I think there definitely we had I had some impact on the techniques between filters, proximal protection, kind of stenting. With regard to TAVI and coronary, well, I was pretty much for complex in the beginning together, and maybe with some live cases we taught something that I had this very genius-like idea which will remain. Maybe I didn't have, but I don't consider myself as a genius. So I'm a normal doctor who likes to teach and treat.
Well, I think actually you've taught many people, both in Italy, I think around the world. Many people from Greece. Dimitris, and
Yes.
many people actually have really, always are raving about how much they owe you and how well you taught them, and that has helped them in their careers down the line. How many hours do you sleep?
I like to sleep at least 7. So if I set my alarm clock and it says because I go to bed too late, 6.5, only 6, I feel okay. I should have slept longer. So I would say between 6 and 7.
Perfect. And then, in terms of the things that you want to do in the future, what are the things that you're most excited about coming forward? Or do you plan to retire ever, or you'll be working forever?
No, I really hope to retire. So which is different from we here also have Dr. Essa Presbitero still with 75. She his 75th birthday she was celebrating with a TAVI and a rotablator. So I I actually hope that I do not need to do this. I think maybe I'm so lucky that I become a grandfather. So then definitely I have possibility, and my hobbies, which is cycling, reading, and gardening. Uh, I think I'll be happy enough with this. Whether I still will do some private practice and then sending the patients to be treated by my fellows that I trust. Probably some hours a week I will do.
Wonderful. So, if you have to summarize, what would be your top recommendations, piece of advice for people who are fellows or early career and want to grow and become better at interventions?
Um, observe, observe, and observe. If you go to the cath lab, look at the doctor, look of course at the monitor, look at the nurses, try to attend different cath labs, go for definitely some months abroad, because you have to learn from many places, many things. Uh, Focalize not only on becoming an interventionalist, you have to be good at echo. I also always send here my all the fellows, all the doctors also for peripheral, so Doppler of carotids and legs, because well for TAVI it's useful, and if for some reason you don't end up in an hospital but in a outpatient clinic, this is important. You have to do outpatient clinic because the richness of every doctor are his patients. I don't think there are enough interventionalists. It's difficult. Only few can stay in hospital in the cath lab and the patients will come. Generally, you have to find the patients, and it's also good to talk with them before and after. So at least some of your time you have to do outpatient clinic. So you have to spend a lot of time in the cath lab. You have to think about, you have to write articles, but be also a doctor.
Wonderful. Well, Bernhard, again, it was phenomenal. Thank you so much for all this piece of advice and for sharing with us your journey. Again, a phenomenal journey that has impacted again many people around the world. Thank you so much, and excited to keep on working with you in the future.
Efkaristo. It was nice. Thank you, and of course. Really, congratulations for your podcast, for your works, for your articles, your books. And I think in 1.5 months, I already choose the patient that we'll do together.
Okay, I'm super excited. Thank you. Thanks so
Yes,
much.
thank you. Take
Okay,
care.
thanks,
Bye.
Bernhard.
Thank you.
Thank you.
Bye.
Bye-bye. Thank you for listening to the Sensei podcast.